Good afternoon, everyone, and welcome to today's webinar hosted by Better Medicare Alliance. I'm Congresswoman Allyson Schwartz, the President and CEO of Better Medicare Alliance, and I want to thank you for joining us today. Today we're unveiling new research commissioned by BMA's Center for Innovation in Medicare Advantage and conducted by NORC at the University of Chicago, examining the current limitations of Medicare Advantage prescription drug CAHPS survey and recommendations to make this assessment tool more meaningful, actionable, and accurate. This webinar is about how Medicare Advantage consumer experiences are measured and how that information is used in Medicare Advantage. It may sound technical, but I can assure you that the information we will hear today is both easy to understand and important. By way of background, there are nearly 26 million seniors and people with disabilities enrolled in Medicare Advantage today. And as in the healthcare system as a whole, there is keen interest in assessing consumer experience in healthcare as part of assessing the quality of care. There are other measurement tools that examine consumer experience, as well as additional measurements done separately using claims data on the quality of clinical care and health outcomes. Quality accountability in Medicare Advantage has been highly successful. Health plans and providers work to meet both clinical and consumer experience measures set by the Centers for Medicare and Medicaid, CMS, and it has worked. Almost 80% of beneficiaries are now enrolled in high-quality plans. So today we're discussing the consumer assessment at healthcare providers and systems referred to as the CAHPS survey. The survey is required to be done annually. It is sent by mail to a sample of Medicare Advantage beneficiaries by contractors approved by CMS. The result of the survey directly impacts Medicare Advantage plan star rating system. It's a 1 to 5 scale used by the federal government to assess quality in health plans. The scores are made public and they're used in beneficiary enrollment materials. They're also used to determine a plan's eligibility for quality bonus payments. These payments are required to be used directly for beneficiaries to lower consumer costs, enhance care quality, and provide supplemental benefits like vision, dental, hearing, and wellness programs, as well as transportation, meals and nutrition services, meals and nutrition services, care in the home, targeted to individuals with chronic conditions. CMS is planning to double the weight of the CAHPS survey measures in 2023, making them more significant to plans and providers and beneficiaries. So all this is to say, this survey is very important. We at Better Medicare Alliance support holding Medicare Advantage accountable for quality and believe that beneficiary experiences should be a part of these measurements. We're here today because this research found that there are limitations in the CAHPS survey and it should be modernized. The report offers concrete policy recommendations to modernize the survey and improve the accuracy and usability. We hope this work encourages changes in the survey and make it more accurate, more meaningful, and more actionable. By bringing the CAHPS survey into the 21st century with a web component, condensing survey questions to get to the heart of consumer experiences that are within the plan's control, and providing more geographic or provider-specific survey data to plans in order to spur continued improvement. We can do better by Medicare Advantage beneficiaries, providers, and plans alike. That's what our new research today and today's webinar is all about. To that end, I'm excited to introduce our excellent speakers. First, we will be hearing from Caroline Pearson, Senior Vice President of NORC. Caroline has led the research in this report, and she's been a terrific partner throughout this process. Her leadership and expertise are much appreciated. She's a respected healthcare expert, particularly in the areas of Medicare, Medicaid, the Affordable Care Act, prescription drugs, and health disparities. She's previously conducted research analysis at Avalere Health for 14 years and is a graduate of Harvard University. She will present the findings and the recommendations, as well as moderate the discussion with our panelists. And we have two panelists. They are Deborah Paone, who is the Performance Evaluation Lead and Policy Consultant to the SNP Alliance, a BMA health organization. She'll tell us more about the SNP Alliance. And Dr. Paone serves on the CMS RAND Technical Advisory Panel on STARS rating, as I do, and is a technical expert reviewer for the National Council on Aging and the U.S. Administration for Community Living. She holds a doctorate of public health from the University of North Carolina and a master's in health services administration from the University of Michigan. Sarah Scholle is Vice President of Research and Analysis at the National Committee for Quality Assurance. She leads NCQA's work to expand measures for vulnerable populations and leads health equity innovation efforts for the CMS Office on Minority Health. She has extensive experience with measurement using multiple data sources, including administrative claims and eligibility files, surveys, and most recently, electronic health record data. Dr. Scholle holds a graduate degree in public health from Yale and from Johns Hopkins. Before I turn it over to our speakers, I want to let you know that there will be time for Q&A at the end of today's event. You can ask questions during the presentation and discussion by using the Q&A function in Zoom. Now, over to you, Caroline.
And so the question is really, what are those measures and how do we make them the most valuable and impactful possible to improve patient experience? So on the meaningful front, we want to ensure that MA plans are measured on aspects of consumer experience that are important to members. Let's ask members what they're looking for in a health plan and make sure that we are measuring those very aspects of plan performance. We also want to make sure that measurement approaches are capturing the diversity of beneficiaries today. The MA program has grown more diverse each year, and so we want to ensure that the survey really reflects the demographics, socioeconomic status, and health needs of all MA beneficiaries in a meaningful way. On the actionable front, we believe that the data collected through the MA CAHPS should be supplied to health plans in a way that enables them to act to improve performance. The goal here is really to hold plans accountable and to improve outcomes for beneficiaries. And in order to do that, plans need to have access to the data in a way that allows them to problem solve, troubleshoot, and continue to get better at all of these measures. We also want to make sure that the measures focus on aspects of patient experience that are really within the control of the plan. And we'll talk more about that, but there are many aspects of the CAHPS survey where plans feel that they simply don't have a lot of ability to influence because it's things that really fall into the realm of the provider. And then lastly, accurate. Of course, in any data collection effort, accuracy is incredibly important. And we want to make sure that the CAHPS survey is eliciting accurate and complete information from this diverse set of beneficiaries, as well as helping beneficiaries supply meaningful responses that reflect their actual experiences. So helping to reduce some of that burden and improve their memory as they go through the survey. So let's dive in a little bit more on the details of each of these on the next slide. So thinking more specifically about the goal of having meaningful results. What we have found is that the MA CAHPS survey has some opportunities to modernize, to better reflect how care is delivered today, how benefits are designed, and how beneficiaries actually access that care. So for instance, the current survey simply doesn't reflect a lot of recent modernizations in how care is being delivered. For instance, there are questions around care coordination that don't line up well with the multidisciplinary care teams that are often employed in the delivery system to treat complex patients. Furthermore, we don't see any questions on the survey about telehealth or virtual visits, and particularly coming out of 2020, and while we continue to be in the midst of the COVID pandemic, we see unprecedented numbers of beneficiaries saying that they've received most of their care through virtual and telehealth visits in the past 6 to 12 months. And we simply don't have a way to capture those experiences effectively in the current survey instrument. We also want to make sure that beneficiaries that plans are being assessed on topics that are important to beneficiaries. And one of the things that we did in our research is really tried to understand what beneficiaries are looking for when they select a plan. So if this is going to be part of what is helping them choose a plan, what matters to them? And what we heard in doing that research is that affordability, premium, brand, network, and benefits, including supplemental benefits, are really what's most important for plan selection for most beneficiaries. And that some of the measures of consumer experience that are really being measured in CAHPS are typically not something that beneficiaries say is a priority for them in plan selection. In fact, things like ease of enrollment and brand were far and away the winners in our survey. We had 81% of beneficiaries saying ease of enrollment and 76% saying brand is really what's driving their plan selection. And then lastly here on meaningful, we want to make sure that the CAHPS survey is capturing this increasingly diverse membership of the enrollees. Today, about 20% of the MA population is dually eligible. That's record numbers, and that comes with a more complex patient population that really has a broader set of needs around linguistic support, health literacy, and the ability to access both the survey and the healthcare services that they may need. And so I think as we get into our discussion with some of my panelists, we'll hear a little bit more about some of the challenges that diverse populations face, which may not be sufficiently addressed in today's consumer experience measures. Now, moving into actionable, I think that the very first thing is trying to focus on experiences that are in the plan's control. And the real justification for this is that if we want the CAHPS survey and the consumer experience measures to be impactful and to result in quality improvement, we need to be measuring and holding plans accountable for things that they can impact. And so as we look at the survey and conduct research with beneficiaries, we find that questions like, how long did you wait to see your provider? 88% of beneficiaries say, that's really something that is only in the control of my provider. I don't see my health plan as having significant responsibility for how long I waited to get in to see my doctor. Similarly, questions around whether your doctor conducted follow-up, how long you waited for an appointment, or whether you got reminders from your physician's office to fill a prescription, were things that our survey respondents said simply didn't feel to them like they were metrics that were really things that a health plan could influence. The second point here on data granularity is another important one. Today, survey vendors that are hired by the health plans field their surveys, and then they provide generalized summary level results about each of the MAPD plans at a contract level back to those carriers. However, those carriers do not get any sort of patient or even subgroup level information that might allow them to dig in more deeply to better understand where they may be falling short on consumer experience or opportunities for improvement. Now, as I say this, it's important to underscore clearly respondent privacy is critically important here, and so that needs to be thoughtfully considered. But the plans that we spoke to felt strongly that if they had more data granularity, they would be able to act more effectively on that information. And then lastly, accuracy. So one of the issues that has been much discussed, and I'm sure we'll talk about more, is how response rates for the survey have changed. Response rates across the survey industry have been falling for a variety of reasons. And so one of the things that we need to consider when we're seeing lower response rates is how is that affecting data quality? Unfortunately, the MAPD CAHPS, unlike some other federal surveys, do not publish the sorts of detailed longitudinal quality metrics that would enable us to understand how falling response rates could or could not be affecting overall data quality. And it certainly raises questions about the accuracy of that instrument over time. Secondly, is the respondent recall question. We are seeing that beneficiaries simply have difficulty remembering what they're being asked about. So many of us have gotten provider CAHPS surveys after we go to a doctor's visit, and those typically say, Caroline, you saw Dr. Smith on January 5th, and please tell us about that visit. The MAPD CAHPS survey is structured somewhat differently. That survey really says, Caroline, please tell us about your personal doctor over the past 6 months, or your specialist over the past 6 months. So it doesn't refer to a specific visit, particularly for complex or chronically ill individuals. They may have had many visits over the past 6 months, and it may be difficult for them to decide which visit they should be responding to, or how long they waited 6 months ago in an unnamed doctor's office. So I think there are some things that we could do to make that data collection more timely, more specific, and really be getting more accurate information from beneficiaries to ensure that we're really informing consumer experience in a meaningful way. So with that, I'm going to pause. And that was a very quick review of some of the things that we heard from our interviews. I'll invite my fellow panelists to come on video and get in on the discussion here. And I'll ask, maybe Sarah, I'll ask you first. I think you've been a strong proponent for trying to modernize the CAHPS survey to make sure it really reflects the way care is delivered today. And so I'd love to have you tell us a little bit more about the way that you think about that alignment or lack of alignment, as it may be.
Thanks so much, Caroline, and thank you, Congresswoman and Better Medicare Alliance, for actually providing a forum to have this discussion. And overall, the idea, for meaningful, actionable, accurate results, I mean, that is something we all want for all of our measures for healthcare organizations. And I do want to say, I believe that CMS and the investigators that support the CAHPS set of survey tools are really aware of these issues and are working to improve them. CMS has been working on web-based data collection. The CAHPS team has released a health plan survey that addresses and a visit-based survey that address telehealth and virtual visits. And also, the CMS does address some issues around generalizability and how they report and score the results. That doesn't take away from kind of the general need to say, wow, response rates are coming down. The perspectives of individuals as consumers in our culture is changing. How we think about how we rate all of our experiences in service sectors, in everything, that has really changed. And at the same time, we're asking healthcare organizations not just to do this once a year for the purpose of accountability and scoring, but really to do this with a mind towards helping to find and ferret out the situations where individuals are having challenges with their health plan. They're having challenges getting access to care that they need. And so I really think that high level, we really need to rethink how we address care experiences, how we find out about it. And we need to think about it from the perspective of the different needs that different individuals have. So people with complex needs, the pieces of their experiences that may be relevant are different from others whose health is generally pretty good. We know that people from different racial and ethnic groups have different ways of thinking about their expectations for care. And so are we actually looking and asking questions that actually allow them and give them an opportunity to express their concerns about whether they're getting a fair deal in the healthcare system and from their health plans? So as we think about this, one of the things we've been trying to do at NCQA is think about, wow, we're moving into a world where we providing a lot of more care digitally. We're looking and we're seeing that people are using other kinds of tools to rate their experiences. How do we take advantage of that and think about a different way to get to meaningful, actionable, and accurate data?
Great, and we'll certainly circle back on some ideas about how we might be able to do that. But Deborah, let me turn it over to you. Sarah mentioned specifically some of the unique needs of different kinds of beneficiaries. You work with diverse and underserved beneficiaries all the time. So let me have you speak to some of those issues.
Sure, and just because so many individuals don't always know what special needs plans are, we're a special subset of the Medicare Advantage world, and the SNP Alliance, which is Special Needs Plan Alliance, represents about 2.3 million beneficiaries, 400 plan options, about 26 organizations. So the focus is on the complex, high-risk, specialized individuals who may have behavioral health, medical health, physical functioning issues. Some are advanced illness. Some have some very complex chronic conditions, multiple chronic conditions. And there's different kinds of plans types. For example, some special needs plans solely focus on people living in an institution. So the state has determined that they need an institutional level of care. They were not able to be maintained at home. Perhaps they didn't have family. And so they reside in a nursing facility. Others have specialized complex care, such as 100% of their beneficiaries have HIV/AIDS. And others focus on primarily 50% of their membership are people under 65, so 18 to 64 with physical disabilities. So I just want to give you a sense of the range of people who might be answering the CAHPS survey and the complexity of physical, medical, mental health, and social support needs. On top of that, most of the membership serves people with high social determinants of health. So they may have housing instability, food insecurity. A lot of the things that we're seeing here and hearing more about now with COVID, but they've been there before COVID, and the specialized needs plans have focused since 2003 when they were first available via an act of Congress. And so that is a special set of people that we focus on, solely focus on. And given that, we, with others, of course, have been asking, I guess you would say, and advocating and trying to educate and be educated around these complex needs, looking at surveys like CAHPS and how would a person fill that out if they had 3 or 4 specialists, a behavioral health therapist, were getting personal care assistants coming in their home. Do they have the understanding of what the survey is actually asking them? So I think not having the context, not knowing who that person is responding with regard to 6 months, what, as you described, Caroline, what might have happened to them in the last 6 months and who they saw and how they were, their experience of care. Even if we had perhaps ability to look at the multiple providers that were seen, how would one ferret out just one person or one experience? So the survey for that population, I think, particularly in some of the issues you raised, Caroline, in your report, it really has challenges, and we would love to see a way that it could be tailored or customized so that, again, it is meaningful, actionable, and accurate. And of course, we have the lens of those complex populations. I hope that's answering your question.
Yeah, absolutely. I mean, I think I'm hearing a little bit of an echo. I think we're both focused on. You mentioned many things about sort of how folks are actually receiving their care, where they're living, how they're accessing that care, and then there's of course sort of a separate set of issues on how they're responding to the survey and the extent to which they are in a position to receive it, understand it, and respond to it effectively. So I think both of those points are really important and ones that came up repeatedly in our research. I'd open it up to either of you. One of the things that we talked about with response rate, as we think about response rate, there's many things that factor into that. But one of the things we heard a lot is the length of the survey is really quite something, in addition to the sort of paper mode by which it's administered, which in this day and age is just not how many even Medicare beneficiaries like to sort of receive and provide information. So any thoughts from either of you on sort of what you see as some of the challenges that may be driving response rates or concerns about data quality?
Well, there's actually some research that shows really it's not about the length of the survey, that people that are engaged will fill it out. I think that it's that's something we really have to think about in this world. I mean, it feels like it's flipping, and certainly in the commercial and Medicaid side. So at NCQA, we're looking at health plan surveys across the spectrum, and we see that in commercial and Medicaid, our response rates are down actually below 20%. And if you see the kind of decline that's happening in the Medicare surveys, you can kind of expect that another 10 years when some of us might be there, that we might be bringing habits from that occur now into that future. And that's really where we have to think about, well, what does that look like now? And that's where the experience outside of healthcare tells us that there are different ways to address these issues rather than one long survey. Maybe targeted surveys to individuals based on their backgrounds, their experiences, their needs, and then using that information to roll it up to some sort of health plan rating so that it's more timely, more directed and targeted, but it still gives us, how well is this plan doing, but it's also lessening the burden, lessening the expectations, particularly as we go to perhaps web-based, but also text-based, other kinds of electronic surveys, where I think we'll see less kind of stick-to-itiveness of going through the surveys. That's not what we're being asked to do on our iPhones now when we're asked to rate other kinds of services. So is there something to be learned there and to take advantage of it so that we are thinking about how do we do that and how do we do it in a way that honors individuals' privacy, that supports their honesty and willingness to provide, real information about their experiences at the moment in time, but still allows us what we need, which is how does this health plan rank compared to other health plans? And, we have really relied, and we've seen that CAHPS gives us that accountability picture. And that's been the focus. And now, we're increasingly being asked to say, look, accountability needs to be tied to quality improvement. I've got to be able to put those two things together. And so that's really the call that we've been hearing. We want to be able to improve things for people who are experiencing problems. So how do we do that in a way that it's not, duplicating surveys, that it's actually getting more real-time information, but also showing that organizations and giving them the opportunity to show that actually, we found a problem, we're solving it, and we're working to do that. That is, I think, sort of a technical and research challenge that we need to address, and we probably have some opportunities to do that. That's where we'd like to see the future go. It's not that what's happening today is very reasonable for where it came from. It's just if you look to the future, we know it's not going to work. How soon can we get there to build that future?
Yeah, and every time we put more emphasis in any given tool, it's a good opportunity to look at it and challenge ourselves to continue to make it more of what we were hoping to be rewarding, right? I think this is a good opportunity to pull up the policy recommendation slide. I'll talk through those briefly, and then we can reopen it for discussion with Deborah and Sarah. So I think, sort of coming out of the findings that we mentioned, we have sort of 4 overarching sets of recommendations. Number 1, really trying to sort of modernize the MA patient experience measurement to reflect how care is delivered today. That really means considering questions that address care teams, so that folks can provide feedback about sort of multiple members of a single care team and how they're working together. Questions about virtual visits and multiple modes of receiving care, and additional user testing to really sort of understand how people from different cultural backgrounds may be understanding and perceiving their experiences and the way that the survey is asking about them. The second recommendation is to provide more granular results to health plans while protecting beneficiary confidentiality and empowering plans to really do more on the quality improvement front. I think this is an area that needs a little bit more exploration. There are very sophisticated de-identification tools now that might actually enable more respondent level data to be provided to the plans without compromising confidentiality. If that's not possible, I think additional detail about both the sort of demographics of beneficiaries so that plans can really target the folks who are having the most difficulty, as well as details about sort of where in the care continuum or which specific providers may be a recurring source of poor beneficiary satisfaction so that they can really target their interventions. The third recommendation is to tie plan payment to questions that plans can directly impact. This is really sort of twofold, but as the weights get bigger, we do raise those questions about sort of how much can a plan affect the weight in the physician's office. And I think this is a complicated one because certainly experiences in clinical settings are important to overall consumer experience, and they're sort of part of what plans need to be thinking about. But there may be sort of creative ways to hold plans accountable for members' overall health experiences while really putting more emphasis on the things that plans control, which are also incredibly important to beneficiaries. How quickly were my services approved? Did I have to go through an arduous prior authorization process? Could I access my supplemental benefits quickly and easily? Those are things that are very direct to health plans and very meaningful to their enrollees. And then lastly, really sort of exploring a range of options to improve data quality and reduce respondent burden so that we are making sure that as this tool becomes more important in star ratings, that the data is high quality. So, should the survey be shortened? There are a lot of provider questions that if we do decide they are important, they're also being collected in provider CAHPS, and there may be creative analytic tools to incorporate that data without actually asking those questions multiple times of the same respondents, as well as sort of just the small best practices around cluing folks into which services, which visits we're asking for feedback on. And then lastly, really thinking about web mode, which may or may not be critical for response, but is certainly critical to modernizing and reaching folks where they are in the way that they want to be reached. So I'll re-invite Deborah and Sarah to chime in on any of these. And Deborah, you looked like you were prepared to make a comment before, so let me turn the floor to you.
Oh, thank you. Well, once again, I think you've captured the beneficiary input very well and summarized. So I endorse all of those comments. I guess I just wanted to say a couple of points. First, and this is probably an easier fix, thinking about the Medicare CAHPS, and Sarah mentioned Medicaid CAHPS, survey response rates going down, duly eligible, which are the people who are enrolled in special needs plans. They're eligible for both programs, and the programs are still fairly siloed, including many states require the same person to fill out the Medicaid CAHPS and the Medicare CAHPS, and many questions are the same. So some states have been able to integrate that, and of course that reduces the burden of the person to have to fill out the same survey twice. So that's just a small example of even just using exactly what we have. There might be an opportunity for some better coordination for those individuals. But then picking up on Sarah's comment about trying to get the participants' feedback or the beneficiary feedback as close to the episode of care or the point of care as possible when it's fresh in their mind, when that person has, important information to share, whether that's really on the provider side, but then those can be grouped so that where those providers are particularly involved with specialized chronic condition populations, somehow the plan could learn from that in a person, anonymous or de-identified way, either through, as Sarah was mentioning, perhaps grouping persons with like types of characteristics together to understand, well, what's happening to these people in these clinics. That's an idea, or grouping by provider, groups or by chronic condition groups, even if the survey was not specific to any clinic and you didn't know exactly who saw the person. At least you would understand people who are very frail or young people with physical disabilities. What are they saying in a more sort of global, regional way? But the closer we can get to what Sarah was mentioning, the goal of having this information inform quality improvement, whether it's by the providers or by the health plan, and hopefully those things can come together. I think that is the goal, just having a score or a star or something, that's fine for its own purposes, but we want to drive toward improvement. And I do really emphasize, don't forget the people who are linguistically diverse, may not understand the wording, have a different ethnic background, have low health literacy, may not have access to the web-based tools because they don't have access to Wi-Fi. They live in a rural area, there's no broadband, they don't have an iPad, they don't have a smartphone. So just keep those people in mind, and whether it's measures or methods being tested, new instrument wording, whatever it is, I always advocate to specially focus, have special subgroups, focus groups, whatever, with those kinds of individuals, the variety of people who might inform, so that we don't leave them out. Because as we look toward that horizon, as you're mentioning, them is us. And I think they don't always have a voice. So that's part of our role. Thank you.
Absolutely, thank you. I'm going to remind folks that we're going to open for Q&A here in just a moment. And so you can continue to enter your questions into the Q&A box. And we will try our best to give you our thoughts on those. Sarah, I'm sorry, were you getting ready to chime in there?
I just wanted to say that this is a great conversation, and really interested to hear what folks listening are thinking here. I think the question of how do we capture experiences that will really help health plans do a better job in their core functions and help them work with their networks of providers more effectively. I think those are really important issues and unlikely to be captured, by some of the kinds of once a year surveys. So that issue of when you look for a provider and you couldn't figure out how to find one in your network, right? Or those kinds of questions that might, or the issues that lead people to disenroll from plans. Those are the kinds of things you want to capture while it's happening, and really help health plans to improve on, or really encourage them to figure out how you really bring those to bear. And I know CMS has other kinds of data sources they use for that, but we need those to be part of the set of tools that we encourage health plans to work on as well.
Yeah, Sarah, I just want to echo that point because I think it's so important. And this is something that really came up. We did interviews with a number of beneficiaries, and those points were things that we really heard. I think often when we think about consumer experience or patient experience, you think about some sort of direct interaction in a healthcare setting from human to human. But when you ask people about their plan satisfaction, these issues about benefit design and network availability and problem solving any of those issues, with the plan are what people really raise as important to them. And so, sometimes from a policy point of view, I think we say, oh, we don't need benefit design to be part of consumer experience because it stands on its own. People have that information when they look, but how well they can understand those benefits and whether they could access them and how long they had to wait for them were things that people really mentioned to us. We had beneficiaries say, I dropped out of this plan because I had a difficult experience with some sort of appeal that didn't go the way that I wanted it to go, or I joined this plan for this supplemental benefit and the getting into that benefit was so easy and that was wonderful. And I recommended it to all of my friends as a result. So, I think this expanded notion of actually what people care about from an experience point of view is really an important lens for us to consider. Let me pause and Deborah, see if there are questions from the audience that we should address.
Absolutely. Thank you, Caroline. So one of the questions that came up is asking if you can provide some examples of metrics that would be used in data granularity in the future.
Yeah, so I think this question speaks to the idea of providing more detailed data to the health plans and how you would do that. That's how I'm interpreting it. And if one of you guys interpret it differently, you can chime in. But and I think, again, I actually think there are probably ways to give individual level data that could satisfy privacy concerns, but let's assume that you couldn't. I think, Deborah, you mentioned, the notion of trying to at least say, let's group like beneficiaries and look at how did responses vary by race, ethnicity, by age, by dual eligibility status, by geography, by provider type, just to make those responses things that where to sort of target. Consumer experience is much about as much about creating positive experience as it is about addressing negative experience. And sort of averages are hard to work with. So having a sense of where are the problems and where are the high points and doing more of the high and less of the low strikes me as sort of the notion of where we need to get to make that data really useful to the plans who are receiving it. Sarah or Deborah, anything you want to say on that front? No? Okay.
I think you got it.
Okay, great. Wonderful. Thank you. Deborah Estes, I'll turn it back to you.
Thanks, Caroline, and thank you for that answer. Another question that came up is actually a twofold question, so it's a two-parter here. Do you expect to experience any pushback around this idea of the changes that we're proposing? And then one of the other questions is, could you just sort of talk through any sort of review that's done of these assessment tools that occur throughout the years?
Sarah, I actually might ask you to chime in on this. I think if you're willing.
Sure. So actually, I think there's actually pretty regular review of the results and thinking about, is this in the right direction? So I do think there is a periodic review. I think it's sort of balancing sort of what is the how much incremental change can we make from year to year when we see what is riding on these results. Okay, so that actually the fact that these are weighted in stars makes it really hard to make changes, but from year to year, or a big change, because the organizations that are being evaluated are in a position of not knowing what to expect, how to improve. And so I think that in fact, because we've been so successful in making this a big part of how we evaluate organizations, any kind of change is going to be challenging. And we have to really think through that change management process. And so it is, making a change from an approach for measurement that we've been doing for 10, 15, 20 years. It's really hard to do that without sort of laying out a strategy for avoiding unintended consequences, for making sure that, you know, we're actually achieving the benefits that we're looking for, and not that we aren't disadvantaging organizations that have been doing a great job. So it is a thought. It's going to require a thoughtful process, but imagination and you know, really pushing forward. And that's part of what, you know, we've, you know, that's why NCQA is, you know, out saying we've got to tackle this issue. We've been worried about it, but we've really got to tackle it, because we can inch along, but we're not going to be able to do it. And we need to start thinking now and building the plan for change.
Great.
Do you mind if I weigh in, Caroline? On that
Please,
briefly?
Deborah.
So just to add to what Sarah's saying, and I affirm all of that, is there are small steps, such as doing some of this subgroup analysis. So you're not changing the instrument at all, actually. Or perhaps certain items can be tested and see if they are still reliable, valid, accurate for certain subpopulations. And if not, those items could be taken out for those kinds of people. I mean, there's ways of tweaking to move toward a better, more accurate, meaningful, and actionable, which is the goal as you laid out. So I think there's actually quite a number of opportunities to make these small steps and at least be transparent on the results. That could be done, you know. I mean, I know that's not a wave of a magic wand, but if it's just a matter of regrouping and reanalyzing current data, not changing anything else on methods or response rate or anything, that can be done. So I think it's probably going to be iterative, and we learn. There are some organizations that have suggested a pretty big overhaul. We're reducing to a very small set of core measures, and perhaps, you know, setting aside, given all the comments on measures and methods, et cetera, that really are shown, you know, the data quality may by now be really not useful or not accurate. So some are proposing a pretty big fundamental overhaul, as you probably know. So there's the range of options out there. But I think, you know, today we could start with some small steps.
I think that's a great point, Deborah. And I you know, we captured a lot of input for this report and present lots of ideas and possibilities. And they, you know, they don't, it's not a comprehensive overhaul solution, right? It's here's a lot of ways in which we could continue to incrementally improve and make this measurement more relevant and modern. And, you know, you could do some of them and it would go a long way. And you know, doing all of that while testing and ensuring, to Sarah's point, continuity in the impact, both to beneficiaries as well as to plans, is of course critically important. Congresswoman, you're on.
Agree with all that's said. I just wanted to add that because the weighting is going to change, doubling in 2024, that well, I completely agree that you want continuity, and changes has lots of implications. But certainly, if they're really going to be matter even that much more, it's really a very timely conversation to have about how to translate the conversation we're having today and the research findings into how you can make changes, small or large, that actually would be much more impactful for beneficiaries and, you know, more actionable and accurate for the plans to, you know, to meet.
Yeah.
Because the goal is make things that you can actually act on and approve before you double the weight on the counting of how they counted. So just one more thing another little pressure point about why this is so important.
Right. Yeah. The next question I see, Deborah, I'll jump in here from my former colleague, Christy Teagland. Hi, Christy. Good to hear from you. Christy's been very focused on the risk adjustment that actually goes on, sort of prior to the input into the MA star ratings around weighting the social risk factors. That's not something that we got into in this report. And actually, Christy's done, I think, more work than any of us on that topic. But I think it underscores another area on this notion of modernization, right? As the healthcare system writ large begins to understand the importance of social needs in overall health, and actually MA plans have really led the way in beginning to address some of those social needs as part of their benefit design, their care management model. We're seeing lots of creativity and activity on that front. That's also something that hasn't really been captured historically in the CAHPS instruments, right? And so again, just a way that we recognize care delivery needs to change. And then if we think that's important, we should be measuring that as part of our consumer experience. So I don't have a direct answer for Christy, but I do actually think that you raise a really important point around modernization writ large. Deborah, I know we're reaching the end. Do we have any additional questions?
I think at this point, we'll go ahead and turn it back over to the Congresswoman.
Wonderful.
Well, let me just first say thank you very much to Caroline and to Deborah, and both Deborahs, and to Sarah as well. Really a great way of taking what is a pretty long report and condensing it into really a meaningful discussion, and really appreciate the thoughtful answers and conversation about next steps we could take and how we can do that thoughtfully. But I know that SNP Alliance and NCQA, we work closely with both of them, and we really are just very appreciative of your taking your time to be here today with us. I want to thank also the audience, and all of us joining us. We had well over 100 people register today, and really excited about that kind of interest. Sometimes these kinds of measurements and parts of the way there's accountability for healthcare, including in Medicare Advantage, seems sort of in the weeds and separate, and somebody else is taking care of. This is when we really appreciate there's been so much interest in the consumer experience and how we can best measure that and act on it. So thanks for all of you. If you have additional questions or comments, you want to be in touch with Better Medicare Alliance, by all means, I think you know how to reach us. And please let us know. We'll try and answer any questions that we didn't get to. I also wanted to say that I'm now sort of going to treat everybody who did sign up as a part of the BMA community and make you subscribers to our policy alerts. It's a way to get timely and factual news on Medicare Advantage, and with 40% of Medicare, over 40% of Medicare beneficiaries in Medicare Advantage and growing, as Caroline talked about. It's an important part of Medicare. If you're interested in work on Medicare, to take a look at both all of the information we have on our website. We have a resource library you can check out. We have a state-by-state enrollment map. You can look, if you work for a congressional office, you can look to see how many Medicare beneficiaries are in your district, and a little bit more about them and about special needs plans. We also have a list of our congressional champions who really have spoken up and been really helpful on the Hill on Medicare Advantage. We thank them. If you represent them, thank you. And we're happy to have that list continue to grow. We are going to post the full report. It should be posted sort of during this webinar, so it's available on our website, as well as our press release, as well as a very helpful one-page fact sheet that sort of summarizes the report as well. So you can go to bettermedicarealliance.org and check that out. And just one more moment, if you are interested in learning more about Medicare Advantage, if you're by all means join us at our next webinar, which is going to be a Medicare Advantage 101, which will talk more about enrollment trends and characteristics of our enrollees, about some important work that Medicare Advantage does in care coordination and the improvement in care, some of the findings we've had, some other research on high need, high risk beneficiaries, social determinants of health, maybe even some comments about the work being done on disparities and health equity. So we're going to try and pack a lot into that Medicare Advantage 101. It's going to be on February 17th, and we'll be sure to send you an invitation. So thank you to all of you. very much appreciate the conversation. Be in touch with Better Medicare Alliance. And as always, given the world we live in today, be safe, be well. Take care.